So I know y'all are smart. I'm not going to sit here and say this is a stop sign, this is what you should do. We're going to make it a little more fun. Next slide. So why are we talking about this today? We want you guys to stay alive and keep your license once you get it. We want you to just keep in mind you're not the only one on the road. And even if you're doing something right, it doesn't mean others will. So you need to kind of be aware of other people's actions as well as your own. And then we want you to be safe and have low car insurance rates. Whether your parents are paying for it or you're paying for it, the average car insurance rate is about $2,000 without an accident. Once you get in one, it goes up to over $3,500. And that's even without $2,000 of property damage or someone filing a claim against you. Next one. So in Georgia, motor vehicle accidents are the #1 cause of death, but they're also the second in cause of hospitalizations. And we wanted to talk about this because for each death, there's 18 people hospitalized and there are 400 that have medically attended injuries. So they may not have been an inpatient in the hospital, but they went to the hospital or their doctor to get their injuries treated. And this is a really heavy burden on the health system, and taxpayers actually pay a lot of this because all these people are going to the ER with or without health insurance. Okay, next one. So let's go over the basics. So Georgia's #6 in the nation for fatality rates linked to lack of seatbelt usage, which is really high out of all the number of states that we have. And greater than half the teens who died in crashes were because they weren't buckled at the time. And when you use a seatbelt properly, they reduce the risk of fatal injury to front seat passengers by 45% and the risk of moderate to critical injury by 50%. And I have a real life example for why seatbelt is so important. So for speeding, greater than 1/3 of teen motor vehicle accidents involve speeding. And so let's say you're going 20 miles per hour and you slow down to 10, or going 10 and going to 0 because you're stopping. It's the equivalent on your body of being hit from an 8-foot fall from a roof. And then, so on the right, you can see a picture and you can see how much you can visualize when you're driving based on the speed. And you can see also by the speed how likely it is that a passenger hit on the road will have a fatal accident. And then at the bottom, you can see just how long it can take to stop. So let's say you're on the highway, it takes you 21 meters to even realize you need to stop, and then it takes you 75 meters, which is 24 car lengths to actually stop. So when you're tailing someone on the highway, there's no way that if they slam on their brakes that you're not gonna hit them from behind. So here's some examples. A lot of Augusta is about 35 miles an hour. So even then you can get whiplash, concussion, back injuries. And if you get hit going 40 miles an hour, it's about 2 elephants hitting your body. And at 50 miles an hour, you have a 70% risk of injury, which is like a broken bone or, a concussion, and a 52% risk of a serious injury like traumatic brain injury. At 56, you can have severe neck and brain injuries, broken legs, and high risk of facial fracture from it hitting the steering wheel. But just so you know, you can even get whiplash as low as 15 miles an hour, which is like when I'm driving in the parking lot. So just be careful. For aggressive driving, this can count as anything with tailgating, speeding, blocking another car from passing. If they're on your tail and you're trying to show them up or whatever, You can get a ticket for this if a cop catches you, and it can be $5,000 or up to 12 months in prison plus 6 points on your license, which is crazy. So distractions, they're involved in 80% of crashes. Human error is the #1 cause of motor vehicle accidents, and the leading factor in this human error is distractions. 80% of people actually admit to blatantly hazardous behavior while driving, like texting, doing their makeup, eating, shaving, changing their clothes. So don't rely on others to be safe for you. So cell phones is the #1 cause of distractions, and people distracted up to 10% of their driving time. So if you're having a 20-minute drive to school, you spent 2 minutes just looking at your phone, not at the road. And it slows your reaction time to basically that of a grandpa. So don't think that you're actually good at multitasking. It's not true. And then let's say you use talk to text or Bluetooth, talking on the phone. On the right, you can see a picture of when you're not on the phone, how much you can view. And when you're talking on the phone, it narrows down so much. So when those people are jaywalking on Wrightsboro or Walton Way, you're not going to see them coming in until it's too late. You're still 4 times more likely to crash, and your brain is processing about 1/3 less, and your reaction time is 2 times as slow, which is equivalent to DUI. So music. I listen to music. I'm not saying you shouldn't. The good is that it can impact your mood positively, so you're less likely to get road rage or something like that. But your alertness can be increased if you have a long drive up to Atlanta. But the bad is that if it's really good music and you're jamming out, your concentration can decrease by 40% and your reaction time slows. So you want to do some happy music. You want to listen to like Drake's Tootsie Slide, not Jumpman and go all out and like get wild, because you're more likely to get a traffic violation. So peers, a teen driver's risk of death per mile driven increases 44% with 1 teen passenger and 300% with 3+ teen passengers. So if you're driving 3 miles, you're doing it 44% times 3. And then teens alter their driving behavior to conform to passengers' attitudes. So this is a good way to subtly influence your peers, because they did a study and they had a stranger come in to be with a teen driver, and one time they were like, "Oh, I'm so sorry, I was just going slow. I was a little nervous this morning." And then afterwards, the teen drove slower and more safely. Or they had another person come in and they're like, "Oh man, I was rushing over here. Sorry I'm late. I sped through some yellow lights." And the teen actually drove way more aggressively, even though it was just a total stranger. So if you act like, you drive slow, and then it can make your friends also drive slow, which is great. And then this picture below is actually something that happened last year on Walton Way, just to reinforce that there were 3 teenagers, I think they were 17 and 2 18-year-olds, and they hit a tree on Walton Way, and all 3 of them died immediately. So it can happen in Augusta as well. Okay, so let's talk about being under the influence. So most likely, most commonly talked about is alcohol. Y'all are going to prom tomorrow. You have no excuse. You have Uber, you have Lyft. Look at the cost of calling an Uber. It's like $6 compared to DUI, jail time. There's absolutely no reason. Call a limo, call your friend, do whatever you need to do to stay off the road once you've had a drink. 29 people a day die in drunk driving accidents, and 8 of them are teenagers. And 5 people a day die from just having a little amount to drink. They've been under the legal limit. And then even without deaths, even more people get hurt every day from drunk driving. So becoming more popular, marijuana, as more states are legalizing it. Just so you know, you're still 2 times more likely to crash. And you know how people get, you've seen them on movies, they become real stupid. Okay, imagine them driving, it's on the highway. You're not gonna have good visual acuity, you're not gonna be able to stay in your lane. And let's say you're in one of the states for college that you drive under the influence of marijuana, you can get a $1,000 fine, a year in jail, and 40 hours of community service, and then probation. And just so you know, they tried this out in Colorado where they set a legal limit for marijuana, and it was 5 nanograms, but on the right, you can see this little chart, and the first arrow is after 1 hit, and they're already above at like 15 nanograms. So essentially, after 1 hit, you can still go to get a ticket for being over the legal limit. So you just shouldn't do it at all while you're driving. And then just to show that you're not just as fine driving high because you're relaxed. In Colorado, since the legalization, the number of fatalities and crashes with drivers using marijuana have doubled. Okay, so this most likely will apply to y'all. You're very sleepy, you're studying a lot, you have sports. So teens should get how many hours of sleep per night? Think about it. And the actual answer is 9. Okay, so how many teens get this amount of sleep? So they did a study. Think about your answer, like 50%, I don't know, a lot of people are asleep good. It's actually only 10%. So a lot of y'all are not fully alert. If you've been awake for 24 hours, you pulled an all-nighter for your test, you're going to a party on Friday to relax, you've been awake the whole time, it's the same as driving over the legal limit of alcohol. Like, y'all are that impaired. And then drivers 16 to 25, which is your age, cause greater than 50% of all drowsy driving crashes. 1 in 7 people admit to falling asleep at least once. I know y'all have sometimes dozed off or something. Have someone else drive for you. So what's important again? Don't depend on other drivers to be responsible when on the road. You need to do it. Don't drive under the influence. Don't try to multitask. Just wait till you get to school to finish your makeup or eat your breakfast. Don't get road rage. Or don't drive the tank on empty or get a flat tire. Your parents will be pissed. It'll ruin the tire and it'll ruin the car and they may not trust you again. And then don't speed because you're late. Do wear a seatbelt. This is really important to me because I actually got in an accident. I was on the highway and there's traffic and I came to a stop and this big F-150 came behind me at 60 miles an hour. I could see him rolling up and speeding and he was looking down and he crashed in the back of my car. He totaled my car, totaled his car. I got a concussion. If my car had been turned at an angle, it is very likely that I could have died. So it's very serious. It can happen to anyone. This was on I-16. It really is a lifesaver. So for prom, call ride-sharing apps, call a friend, call a parent. That's cool. Just don't drive yourself. Choose soft, happy music. Let your friends reply to your texts for you. Be your co-pilot. Do the GPS. Use your blinkers. I hate when people don't use your blinkers. I'm not a psychic. I don't know what you're thinking. So don't try to pull into my lane without letting me know, okay? Y'all are smart. Don't mess up. You want to go to college. Be a good driver. So now we're going to go into simulation. We're going to show you some pre-recorded scenarios of some patients that are car accident victims. And so when y'all are watching this video, try to think of questions. Stephanie's going to make sure that you each ask a question for every accident victim that you see.
All doctors in the ER.
We got 4 18-year-olds.
Do you want to pause it really fast?
go for the shin, put an IO in.
There's no breath sounds on the right?
All right, collapse lung on the right. Let's get a chest tube.
Code blue, roll 305.
Absent pulses. Patient is not breathing. Starting compressions. Code blue.
I'll bag him. Code blue. Getting tight seal.
I need 2 bores, and we'll switch in 30.
I need a blood gas. Okay, access tank pads. All right, 2 breaths. Good chest rise.
I count on 3.
3, 2, 1.
Hey, can I get a glide scope? On the way, on the way. Do we have breath sounds?
No breath sounds.
Do we have a pulse?
Yeah, I got a pulse.
All right, let's get an airway set up. Start bagging. Can we get a line?
Yeah.
All right, I'm going for the intubation.
Okay, starting IV access.
All right, tubes in. Stylet.
Breath sounds bilaterally, none in the abdomen.
All right, this patient's unstable. Let's get him to the OR.
We have a shock in the window. Get some epi.
Everybody clear space, spread the flow shot.
Chest tubes in.
Okay, let's move.
Let's go, let's go, let's go.
All right, y'all, we got an 18-year-old male here, Mr. Samuel Jackson. No pertinent medical history, no known drug allergies. He presents for a level 1 trauma, a right anterior tibial fracture.
All right, Mr. Jackson, we're gonna go ahead and put you to sleep for surgery. Take big deep breaths. This is just oxygen.
My leg is hurting.
All right, we're gonna go ahead and push some pain medication for you.
Okay, I'll go ahead and get the fentanyl. All right, getting the fentanyl.
All right, we're pushing fentanyl now. Okay, we're gonna go ahead and push propofol too. You're gonna go to sleep now, Mr. Jackson. Just relax. Okay. All right, the patient's asleep. I'm gonna go ahead and start the intubation. Patient's intubated. I'm gonna send him to the vent. All right, we're ready for surgery.
Hey there, Dr. Bucci. We got a 18-year-old male, Mr. Samuel Jackson. No pertinent medical history, no known drug allergies. Presents for a level 1 trauma, right anterior tib fracture,
Antibiotics.
Ancep 2 grams.
Okay. Right side to correct side.
Correct side.
Okay, we'll call timeout officially at 11:10 p.m. Okay. Can I have the lights dim, please? Scalpel. Thank you. Scissors.
Dr. Bucci, can you stop? Our blood pressure is 85 over 57. Is anything going on down there?
We have some bleeding. I'm trying to control it right now. If you go ahead and push whatever you need to.
All right, Cash, can you give me some blood products and fluids?
Sure, go ahead.
We need to do a
Right on.
massive transfusion protocol.
Fluids and blood products on the way, sir.
All right. We're going to go ahead and push epi too.
All right, gonna go ahead and give you the epi.
All right, pushing epi. Blood pressure is still 85 over 57.
Okay. Yeah.
We're on our second unit.
Trying to control this bleed down here. Go ahead and handle whatever you guys have to do up top.
Pushing more epi. Can we get that third unit of blood?
Sure, right ahead, sir.
Okay. Starting our third unit. Right, the blood pressure is still dropping. It's now 73 over 51.
Yeah, this bleeding won't stop.
Pushing more epi. Nurse Cash, do we have any more fluids or blood?
I'm trying to control this bleed, fellas. Can you pass me another gallons, please? Thank you. What's going on?
All right, we're going into VFib. We may need to shock the patient.
Can we get a defibrillation?
Okay.
Chest compression. All right. You got a pass?
The defibrillator is ready whenever you are.
Okay, we're ready. All right, shock the patient.
Shock ready.
Stand
Clear.
So what we did, like we showed you a scenario of different perspective, what can happen in emergency room after trauma, or what can happen in operating room. So what we'll do now, like we will do the live streaming of some of the scenarios that we just showed, and we'll be like going step by step, very slowly, and you are welcome to actually, will strongly encourage you to ask questions. Because this is going to be now onwards will be very interactive. The more you get engaged, the more you will enjoy it. Any questions so far? You ready for some action?
Let's move.
Okay.
All right, ready to follow?
Let's do.
Yep.
All right, so we're going to have, as we go around, okay, so we're going to see the scenarios that we just saw. And I'm going to ask Stephanie, because I see her over there now. I'm going to ask Stephanie to make sure you guys are come up with a question, okay? We're going to go to each station. I'm going to have these fine doctors kind of explain what is barely. I'm telling Michael to work on it.
If we hear it, then
It'll echo. Yeah.
That's why we can't turn it up.
Okay. So you guys are going to have to repeat the questions out loud then. Would it be easier to walk around with the
Stephanie, you can
laptop?
The
also
farther we
enter
get
in the
away.
chat box.
Get the further we can do that.
Would it be
Yeah.
easier to
So
walk
any
around with the
question
laptop?
if you have, you can enter in the chat.
It would suck.
I think typing it out would be the best.
But we can. It'll work. We'll make it.
All right. Let's just.
All right, guys.
Which
so we're
one do
starting
you want to
with,
start? Yes.
Yes.
Okay. So good question, very good question. So what happened, like when the patient starts bleeding, but the bleeding got very profuse and it was not able to control, so then there was not enough blood in the system, and that's why the heart started to stop, and actually it stopped. So that's why we started chest compression. Make sense? Okay.
Okay. We have another question.
What type of injuries?
This is a.
So it was a motor vehicle accident, and a patient had injury to his leg. And whenever you have accident, there can be other hidden injury. He could have injury to his abdomen or chest that was not recognized. Good? Very good. Okay.
All right. Which scenario are we going to first?
So we go airway breathing circulation. Okay. You all actually come to one station.
All right, guys. So we kind of set this up in a way that you might be familiar with. All right, and that's with the ABCs of CPR, right? We talk about airway, breathing, circulation. I'm sure you guys have heard that all the time. So this particular area, all right, is going to be more about the airway. So I'm going to turn it over to my friend Dr. Lopez over here, and I'm going to ask him to kind of explain his thought process, this terrible accident, unfortunately, that we had to witness. What's going on here, Michael?
Sure. So the first thing in the ED, what we need to do is make sure the patient is stable, and so we follow the mnemonic ABCs. So at this station, we focused on the airway. So you can imagine in a car accident, if you have any trauma to the airway or the front of the chest area, there may be some obstruction. And so what you might have remembered us doing in the video is checking for breath sounds initially. We then checked for a pulse to ensure that there was circulation. And at that point, we knew we needed to secure the airway because, as you guys know, if you go without oxygen, if you can't ventilate your lungs, you'll decompensate very quickly. Within 2 to 10 minutes, you can die, basically. And so what we did was we placed a tube into the windpipe or trachea of this patient, and we did that using a glide scope, which is a video assisted scope that we can use to move the soft tissue out of the patient's front of their mouth and visualize the vocal cords, which is where air goes into the patient's lungs. And once we've done that, we can place this tube in and artificially ventilate the lungs. So I'll try to demonstrate this for you now. So as you can see on the video laryngoscope here, that I'm pushing out the soft tissue and I'm visualizing, and those are the vocal cords there in the front. And what we'll do from there is just go ahead and place this tube through the vocal cords. And actually, right now I'm unable to do it because I don't have a stylet in there, but I'll go ahead and place a stylet. It can be difficult because there's also the esophagus right below the windpipe, which makes it difficult, especially in a trauma situation. But there you can see the tube going through the vocal cords into the windpipe. And once we get it in, we'll remove the blade, and then we can start bag masking the patient and delivering oxygen and removing CO2 from the patient's lungs. And that will help us keep the patient alive until we can get them to surgery, get them stable, get them breathing on their own again. Do you guys have any questions about that? Just any basic questions or any thoughts at all?
You may have to translate for us, Stephanie.
So yeah, so this station is about to show you the importance of airway management. I don't know if we always talk about in medicine or in healthcare that airway breathing.
Yes, we can.
Yeah, so the ambu bag would be preferred over mouth to mouth, but yeah, that's right. So if you were out without any equipment, if you're unable to intubate the patient and get an airway, you could do mouth to mouth resuscitation, which is something they teach in basic life support, just to basically keep air moving, getting oxygen in, getting CO2 out as much as you can, and then you do compressions to keep the blood flowing. You're kind of acting as an artificial heart and lungs for the patient.
And I'm going to add this caveat to you guys, okay? When you're doing compressions, you're actually moving a little bit of air. Because you may not know where your patient has come from, you may not know what kind of disease they have or so forth. The number one thing in all healthcare is that you take care and are safe when you're doing this. So if you don't feel safe giving breaths, then I would recommend that you don't do that, unfortunately, okay? So be very careful. That's obviously in the hospital situation while we have those protective mechanisms that we use.
I mean, possibly you could, but it wouldn't be recommended just because it would be really difficult. I mean, I guess you could, almost use it as a straw, but I've never seen that before, so yeah. I don't think that would be something that would be
done.
And
we do have a plethora of options to ventilate through the tube, right? So we have big ventilator machines, right? Those big ones that you see in the operating room that give big breaths. We have tiny ones that we use in the ICU that give little breaths. We have ones that we use for pediatric situations, and then we have ones that we use in the field that are little kind of mechanically operated, battery-powered ones. So there's definitely different options. We have ones that are we call jet ventilator, which just give a big burst of air, kind of like it came out of an air compressor, and we can use stuff like that. So there's different options, and obviously those are very nuanced, okay? So those are going to be very special situations for that, but there's other options that we can use.
And how much oxygen we have in the air? Like normally we have about 21%. And how much oxygen you can give through mouth to mouth? It's even less, that's only 16%. It's not ideal to give mouth to mouth breathing.
All right, I'm going to ask one question to Mary here. I don't know if you guys noticed this down here on this leg. Mary, what is that, and what does that do?
This is a tourniquet, and so a lot of times, if y'all have ever taken any basic life support, if someone on either their arms or legs has a big gash and they're bleeding out, you want to use a tourniquet to apply pressure. And so basically you tie this band around really tight, and then this little rod. Okay. So this little rod is used to twist it and get it even more compressed. And so on a real person, you twist it 3 times, click it in here, and secure it in place. And this way it stops the blood flow down to the leg. And so you can save the patient extra time, and they won't bleed out, and so you can get more time for them to get to the hospital, so they can get them to the OR and fix the bleed. Does anyone have any questions about the tourniquet?
So what side of the injury would you place the tourniquet on?
You want to place it above the injury, closer to the body. So if it's on the leg, you want to go as high up as you can, or if it's on the arm, you want to go kind of close to the shoulder. But another thing is you'd never use it on the neck. I know they teach us that, but it's really just for the arms and legs.
So what can you use if you don't have a tourniquet available?
You can use lots of different things. You can use I don't know, a belt, or I don't know, you could use a belt and then take a t-shirt or a hairbrush and put it in to use kind of a hairbrush as a rod. Do y'all have any other creative solutions?
One excellent question coming on is how long you can keep the tourniquet on?
Oh, that's a great question. So if you guys didn't hear, it's how long can you keep a tourniquet on? I'm going to ask my colleagues here if they know the answer to that.
Is it up to 6 hours?
How long you can keep the tourniquet on?
So I'm getting some varying answers. That's a great question, by the way. So it depends, and I'll turn it around to my orthopedic surgeon here and see if he knows.
Big ortho guy, come on.
Tourniquets a lot in the operating room.
Surprisingly, we actually don't in a lot of the traumas, but it's
whoever's protocol, whoever's running the case does that. I'm going to punt that to my pain management colleague, Dr. Cash.
So from my understanding, I think around 6 hours is kind of like the universal guideline. If you leave it too long, you kind of risk getting some necrosis of tissue.
Yeah. So that's a pretty good rule of thumb. We try to leave them down under 4 hours if we can. Once you get up, like he said, towards the 6 hours, there's so much toxin that builds up after the tourniquet that when you release the tourniquet, all that toxin comes running back into the body, and that's when we get a lot of problems. The heart rate goes down, the blood pressure goes down, and we have to fight those things. So it can be a dangerous situation too. But a tourniquet can be a great thing in the operating room, so we can let our surgeons fix those bones and things like that.
The other question is, would you also pack the bleeding?
Oh,
Yes.
so
You got it.
you got it? Okay. So one thing is, one of the first things we learn in trauma is you always want to apply direct pressure. And always, what we learn is like if you have a t-shirt, you pack it down in the wound, and you only add layers to that and keep on applying pressure. And if you have a tourniquet, that's good because you want to control the bleeding. Applying pressure, collapses that vessel, prevents blood from leaving out and building up. So I can turn it over to Dr. Rankin if he to add a little bit more on that. If there's anything.
Do we have any other questions? If not, we can move on to the next scenario here. All right, so we dealt with airway. So the next part in this ABCs is going to be kind of the breathing. So what are the other complications we have with breathing? So I'm going to walk over here. I'm going to ask Michael to join us. Thank you. So if you guys noticed in the video, Michael was over here with his team.
Yep.
And they were working on what, Michael?
So the medical student you saw on this side of the bed here was putting in a chest tube. So basically, your lungs slide on the inside of your chest wall, and it's like there's a vacuum in there. If any air gets in, whether that's from a broken rib penetrating or from like a bullet wound or a blunt trauma, your lung can collapse. Is essentially what happens, and it pulls away from the side of the wall, and then you get air in there. And then if it's collapsed like a plastic grocery bag, then you can't fill it with air. So what we do is we put a tube in the side of the chest and to pull that air out so that, think of it like that plastic grocery bag can re-expand like your lung would, and then you can get air back in it. If you leave it there for too long, you can survive on one lung, but as that pressure builds in the chest, every time you suck in it puts more air, then it can start putting pressure on your heart or your trachea, and that becomes a problem. So we just go right between your ribs, make an incision, and force it in there. It's not comfortable.
Yeah, it's actually very painful. So, hopefully you don't end up in a situation like this where you need one because, we can give it a little bit of numbing agent, but, there's a lot of nerves and stuff that travel around this rib. So very painful, very uncomfortable. So,
explain what happens when you have a car accident and you may break multiple ribs. Obviously, breaking ribs is something we hear about a lot. Mm-hmm. But what is actually going to happen kind of long term with people that have major broken ribs like this?
Okay, so as you know, if your ribs kind of run like this, right, if you do get into a car accident, they may break and separate. So, and it's very painful. So every time you take a deep breath, there's a layer of tissue called the pleura, and that's innervated. So every time you take a deep breath, it kind of moves. And so that broken rib might poke into that, and it's extremely painful. And later down the line, you might develop a pneumonia, you might develop all these other complications just because you're not able to breathe properly because it's very painful. And that term is called a flail chest.
So one of the problems that we have when somebody has broken ribs like this, the more broken ribs you have actually equates to your higher risk of dying. And that's, maybe weeks down the line. A lot of times people get pneumonias, things like that. And if you think about it, all the pain medicine would allow us to kind of take a big deep breath. But if we give you too much pain medicine, then it stops your breathing. All right? So it's a very tough situation for us to manage, and a lot of people die because of this. So just having a couple broken ribs from a car accident can really be a very serious situation. All right, I'm going to move over. We got another fancy object down here. What on earth is that?
So this is in Home Depot. This is called an interosseous access. So basically, if you remember the C for circulation, if you come in, you're bleeding a lot, your blood pressure could be really low, and we have to administer you blood products and fluids to help you get your circulation back. So in emergent situations, we might not have time to put a line in right here through these vessels. So they developed this, which is called interosseous. So basically, we drill straight into right here, like that. We can.
What bone is that you got there?
This is the tibia.
Very good.
Shin bone.
Yep. So then we can pull this out, and then we can screw in this this catheter, and then we can push fluids through here. So the actual process of drilling in isn't painful, but what really hurts the most is when you start pushing fluid, and it gets absorbed by the vessels on the bone. So it's very useful, very painful. Like I said, we hope you don't ever need this.
Where's the tibia located? There you go. Shin bone. All right, we'll give you a second. We'll pause to see if you guys have any questions about that, either the chest tube or the interosseous IV access.
So there is one question. It says, where in the chest you will put the chest tube?
Oh, that's a great question. Did Stephanie ask that question, or somebody else ask
the
that?
hole? Is the hole on the side?
Yeah.
Oh, yeah.
So that's a fantastic question. So where on earth would you put the tube? So let me bring one of my colleagues over here and see if they can tell me where they would put that tube.
So I know there's the second intercostal space at the mid-axillary or mid-clavicular line.
There you go.
There's also another spot that people tend to use. Fifth intercostal space.
You can go mid-axillary.
Mid-axillary.
Yeah.
So
Is it above or below the rib?
So if this is the rib, there's a bunch of vessels, the intercostal nerve and vessels that run beneath here. So we want to go above the rib, because if you go here, you can get a lot of pain, disruption of blood vessels. So we like to go above the rib. Like we said, it's very painful.
So what he's describing, so if you ever see in Grey's Anatomy, they're going, I can't breathe, and somebody comes along and sticks them with a pen or a needle or something like that. What they're trying to do right up here, if you kind of look right up at the surface, it's very thin right here to get to the lungs. So they're going to stick a needle right here, and this is our second intercostal space. This is the second rib, right? So they're going to stick that needle right down in there, and hopefully, if they're in the right spot, you'll hear a gasp of air. Now, sometimes, if somebody's got a big chest muscle, or maybe they had a lot of fat over the top, it can be hard to get that needle in there, okay? So what we've started to do is we started to come down here on the side, and actually you can kind of already see an artificial hole there. But down here on the side, right along the line, we have all the ribs that run this way. Now, I got to be careful, okay? Because the diaphragm in which we breathe and the liver sits right here. So I got to go above that, but then I have a lot of nerves right here for my arm, so I got to go below that. So I'm going to come right here, and we figured out that the fifth intercostal space, the fifth rib, is the best place to go on the side to avoid damaging all those structures, okay? All right, let's move on to the next section. I'm going to ask Dr. Bucci to join us.
Should I ask them what CPR is? Or
All right.
let's go?
So airway, breathing, circulation would be the last one, right? So this one's going to be the kind of circulation based. Obviously, Dr. Bucci, we have somebody who's got an incredible amount of blood loss. You saw that their heart was very unstable.
Mm-hmm.
What were you doing when we came over here?
So what I was doing was what we call CPR, which stands for cardiopulmonary. Which stands for cardiopulmonary resuscitation. And basically, your brain has about 4 minutes to where it does not receive blood before you have permanent damage to it, which is I want to say give or take is about the same for the heart. I may be off on that. But what I was doing was with palm over the base of my other hand, digging into the chest basically and releasing. I'm trying to mimic essentially what your heart would be, some kind of rhythm to kind of get blood going. You're going a little bit harder than this. And in an adult, what you want to do is the same kind of mannerism that I'm doing. And you want to do 30 compressions, and then you would pause, and then you would usually have an assistant with you if you're doing this in the trauma bay, and then they would bag them and try to ventilate with 2 breaths. And then you would keep doing that up until you got what they would call a shockable rhythm or rhythm. And then that's when this guy gets involved. So this is our defibrillator. Basically, you get some kind of rhythm. You would have an EKG running also, which I forgot. I kind of jumped the gun on that one. But you would have leads placed around this patient's chest. You would kind of get some kind of rhythm going or get a rhythm strip going. You would see it. It'd be in sync with your defibrillator. And then you would then place these pads on your patient, and it would deliver a shock. And this guy's actually active, so I'm going to lay this down before I do something stupid to myself. This guy.
Dr. Bucci, show me on the mannequin exactly where you would put your hands for CPR. Come up here so they can see exactly where you would put your hands to do good chest compression.
So I'm kind of going by the sternum. Your heart kind of sits on the left side, so I'm going a little bit right there by the sternum. I'm going another hand over that. I'm locking fingers, I suppose, and then I'm just pressing down like that.
Now,
So,
how hard do you have to push in order to do effective chest compressions?
you want to push relatively hard, not too violent. Really not too violent, but relatively hard. You want to kind of get in deep like that. So you're pushing against 12 ribs and XYZ. So you want to get hard. The bed is positioned to give you some kind of mechanical leverage, so you can push as deep as you can, and then release, and then just alternate that for 30 pumps.
Now,
somebody asked, would you have to put a board underneath them to do CPR?
that is a great point. So
The board that you put on
the answer is, if the bed does not have a situation, so a lot of these beds are real soft. We try to make them very comfortable for our patients, but you're right. In order to do effective chest compressions, we got to have some stable surface underneath. So some of the beds have ability to harden for us, but if they don't, we have this board right here that we definitely should be sticking under the patient
So
to
then
do that.
your staff or whoever is with you would, on a count, roll the patient over, and then you would kind of slide that board underneath.
Go ahead.
And then you just lay them back down on it.
All right, here's a question. If chest compressions are done correctly, can you break someone's sternum?
Yes. More often than not, that's actually the case while doing compressions, that the sternum does break.
Sounds pretty rough.
Very violent. Something I wouldn't want to deal with when I do come to. And yeah.
Yeah. What other questions do we have about this kind of circulation piece, the CPR aspect? Are they asking?
Yeah.
I got a question. So, which one's more preferred if you could only do one, giving breaths or doing compressions?
Doing compressions is more preferred than giving breaths. More often than not, you'll see, especially out like in the fields. I'd say not necessarily more often than not. Obviously, with healthcare professionals, we can deliver the breaths, in the correct manner. But what you really want to do is get the cardiac output, mimic that cardiac output, and that's where the compression comes in. That's why it's more important than giving them the breaths. The breaths are important, but the compression is more important.
Excellent. All right, now I don't know if we have the ability to go over to the operating room.
Do we have extension?
I don't think we have an extension. We would have to take the actual computer with us. Can we do that?
No.
Just keep it here.
Okay.
We can show some other mannequins.
Can we take the laptop?
It's on, right? Like it's logged in the Zoom call. You have to like.
Yeah.
That would be the
Yeah, let's just do that.
Okay. So we're just gonna.
Don't do that. It could be very shaky.
Oh gosh.
Forgot that card.
Yeah, dude.
All right, guys, I'm gonna turn this back over to our boss, Dr. Wahab, that's over there. Okay. We don't have the ability to walk into the operating room here. The simulation does have a full operating room. We have a lot, as you can see, we have a lot of options in the way we train, a lot of options in the way that we can see different patient scenarios and so forth. And that's why these guys are so good at what they do. They've been through all that. But I'm going to let her kind of guide it from, I guess, that end over there and see which direction we want to go now, okay?
So if that's happening, then you really don't have much time. And it depends on how the bleed is. So is the bleed happening inside of the body? And it's in an area maybe where the blood is being compressed against other tissues, and it's almost helping the patient in that way, because it's not like bleeding out into the like outside world, for example. So it depends on where the bleed is. It depends on the orientation of that bleed, if it's bleeding inside the body, because after a while blood starts to clot, right? And then if it's clotting itself off inside the body, then you have some more time. But if it's just like you see in the movies where they're just bleeding out all over the place, you really don't have that much time. And that's why Michael was saying in Kashif, that's why they were saying the best thing you can do, say you have no tourniquet and person's sitting there bleeding out, apply pressure right away, because your hands are literally stopping the bleed in that moment. And you'll even see in like Grey's Anatomy, like when they bring that the ambulance and the EMT is there and everything, sometimes there will be somebody like running alongside the patient, like holding something. That could be what that is. So you want to keep it stabilized until they can take them into the OR. And then in the OR, they have these like tiny sutures and vascular surgeons who actually deal with that stuff, and they can sit and like repair that tiny vessel so it stops bleeding. It's pretty cool. What's your question? Are there any disadvantages? Yeah, so what Dr. Rankin was saying, how like when you have a bleed and you put the tourniquet on, have you ever like fallen asleep on your arm and then it starts to kind of like tingle? That's because you're actually stopping the blood supply. And when you stop the blood supply, then that area kind of starts to die, and especially for a really long time. When it starts to die, it releases toxins because that's like that tissue. And when that happens, you have a buildup of all of these toxins. So if you were to leave the tourniquet on for a really long time, like that leg would be black because it's dead and because there's no blood supply. So the downside of the tourniquet is even if it's under that 6 hours, you're still constricting, you still have some damage, you still have some toxin buildup. And that's why he was saying when you take the tourniquet off, those toxins that have built up in that part of the leg rush back to the rest of the body because your body's always circulating blood. Now you have toxins all over the body. And that's when you might have to use a vasoconstrictor because the toxins lower your blood pressure. So that's a good question, but it's kind of like this game of like lowering the blood pressure and bringing it back up, but you don't want it, too high, and it can get to be this very fine balance. So tourniquet is not ideal. There's definitely consequences. Yeah.
So when you're trying to clot the blood so that they don't bleed out, what happens if you like give them too much and it becomes an unhealthy blood clot?
Oh, you mean like when you're trying to give them something that could like clot the blood? So you mean like blood products or something? So you know what can actually happen? When that blood, say you have like a person that was bleeding out and you put a tourniquet on, that blood that's down there is just sitting. And like you said, when blood just sits, it starts to clot together. And when you have like a cut on your hand, that's what stops your bleeding, is the blood starts to clot. There are times where that clot forms in the leg, and then it can form like in the veins or in an artery. And when that clot decides to move, it follows the rest of the vessels up to the heart and up to the lungs. And if that clot goes through really small arteries or veins, it can actually get stuck there. And that's an actual condition we call pulmonary embolism, which means that there's a clot in the lungs and the person would have chest pain. They would have shortness of breath and difficulty breathing. Their heart rate would speed up really fast because they're not getting circulation to the rest of the body properly because that clot is like blocking the blood. And so that is a real problem. And especially patients who are sitting in the hospital for days and days because they're so sick. Imagine like they're just sitting there not moving. We actually put them on blood thinners to prevent the clots from happening. A lot of times those people that come in with that condition called pulmonary embolism, they could have just been on like a really long plane ride or a really long car ride. And that's why people say like, get out of your car, walk around, stuff like that, because it gets your blood moving and prevents the clotting. But that does happen.
Stephanie, could you explain to them in reference to if a person is bleeding out, where they would place the tourniquet?
Yeah. So you want to place the tourniquet above the bleed. Does that make sense? Because if the bleed is in the arm and it's right here and you place it below, I mean, you're kind of helping, but it's still bleeding out from there. So it's not very productive. So you always place the tourniquet, like if you see blood spurting out from here and you can't see exactly where to place it, just go up to like here and wrap it around and place it. So it goes above where the bleed is. You guys had good questions. She's like, I'm ready to go.
Are we leaving? Are we leaving? Are we going to
Well, we want to thank Stephanie Wahab and her entire team for providing this opportunity for us. And at this point, I think that the media is here and they want to speak to a few of you all. So you all can hold tight. And before you leave, make sure that you all grab some snacks that's provided. And we also want to thank Ms. Denson for helping us facilitate everything.
Not texting and driving, awesome. So whenever you are driving and your hand starts going to the phone, think and stop. It's very important. So what we try to show today is like some scenarios of accidents, and also we showed like what will happen or can happen after the accident. Like you may end up in hospital, or some of the trauma can be very serious or life-threatening. So that's very, very important lesson. As a young teen, we many times we think like we are very good, we are smart, we are sharp, and nothing is going to happen. But unfortunately, bad things may happen. So always be careful. That's what we call say ABC. Always be careful. Thank you all, and we also like to thank our awesome team. Give us a round of applause. It was a lot of work in the background and to prepare for this and to reach to this stage that we showed today. But it's very exciting, and we'll continue to do more scenarios and more simulation in future with different schools. So thank you all.
Thank you guys. Have a good prom.
Have a safe prom.
Yeah. Safe prom.